Okay. There we go. Good afternoon, members. I call the Committee of Supply, Section C, to order. We are meeting this afternoon to continue the consideration of the budget estimates of the Ministry of Mental Health and Addictions. Minister.
Thank you, Chair. Resolved that a sum not exceeding $40,749,000 be granted to His Majesty to defray the expenses of Ministry of Mental Health and Addictions, Ministry operations to 31st March 2025.
Thank you very much, Minister. I now recognize the member for Surrey South.
Thank you, Honourable Chair. Before we concluded, I was awaiting a response to the percentage, the question being what additional resources are there within this budget that are aimed at increasing retention to OAT?
Thank you, Chair. Yeah, so with respect to connecting individuals who are struggling with opioid use disorder to opioid agonist therapy, our health authorities are working to incorporate that care and that connection as part of the Road to Recovery expansion. Just to go back to the way that Access Central is working in Vancouver Coastal Health, this is a key part of the Road to Recovery program, which was developed by frontline addictions medicine physicians at Providence Healthcare. And in the Access Central model, you have now not just an intake team, but a clinical team co-located with that intake team. So when people are calling in, they are receiving a same-day clinical assessment that helps to direct their care pathway. And in some cases, they are that clinical team is able to connect individuals who call in right away with an opioid agonist medication, which can be potentially called right to their pharmacy. That might be a situation where they are on that therapy while they are holding and waiting for a detox bed, for example, or that might be the treatment that they need. So this budget contains provisions for scaling up that Road to Recovery model in every health authority, and really that Access Central function is the key piece that is the first priority for the health authorities. We're continuing the work to support prescribers and expand the number of health professionals who can prescribe opioid agonist therapy. We now have for nurses a certified practice standard, and we're seeing the number of prescribers increase. When it comes as well to virtual services, we have every health authority either providing virtual service or in the process of scaling up a virtual service that is very much integrated with local services in each of the regional health authorities. And just overall to say that I know that when I talk to frontline physicians and nurses, the changes in the toxic drug supply make it very difficult to be able to respond to the changes that the toxic drug supply kind of prompts in people in terms of their physical reaction. And so this is a constant process in the clinical decision making that is part of this around determining which kinds of medications are going to be the best sorts of medications for people to be receiving. So that is part of the challenge that is being dealt with by physicians, and part of what we're trying to deal with by making sure that these services are really local and connected and quick.
Member.
Thank you, Chair. Thank you, Minister. The Ministry's 2024 service plan indicates an ongoing decline in the 12-month retention rates. So you provided some information about access to OAT, but I'd like some more information about retention. So with only a slim target increases projected in the upcoming years, how does the Ministry justify these modest targets in light of the substantial public health implications associated with OAT retention, and what steps are being taken to ensure that these targets are met and progressively improved upon.
Minister.
Thank you, Chair. What frontline physicians are finding is that the changes in the toxic drug supply, the complexity of the contamination in the supply poses significant challenges for retention. And so the service plan is really an effort to try to be prudent around how we are able to incorporate a response to these challenges. So that's why you see the numbers come down a little bit from the actuals from the previous year, and then slowly seek to build back up. There's considerable work being done by health authorities to improve access, but not just access, to also improve the approaches to how physicians and nurses who prescribe in this area are supported in their work. So there's new guidelines that address dosing and address the appropriate medications and titration methods in this when prescribers are working with their patients. There's also a number of ways in which we're looking to incorporate sort of better access to OAT sooner. For example, in emergency rooms, in our acute care settings, increasing access to take-home doses, really trying to reduce the barriers wherever we can, and have physicians better able to work with patients to keep them stable on the doses, and obviously adjust those as things go along. These revised OAT guidelines have aligned with Ontario. Ontario is experiencing a very similar situation to British Columbia with respect to the impact of the toxic drug supply. And another sort of level of trying to get support to people early is that all of the overdose outreach teams that exist in all of the different health authorities. In Vancouver Coastal, for example, that team has a nurse embedded in that team, so that when they are out working with outreaching to individuals who need assistance, a nurse is able to actually connect them with OAT right away.
Member.
Thank you, Minister. The decline that's been noted seems to correlate with the introduction of prescribed safer supply. Has the ministry completed any investigation or analysis to determine if there's any linkages?
Minister.
Thanks, Chair. No, I mean, contrary to the suggestion that there's a correlation between the introduction of prescribed safer supply or pharmaceutical alternatives that results in a diminishment of retention to OAT, it's actually quite the opposite. What clinicians are finding on the ground is that providing access to pharmaceutical alternatives can actually be a facilitator for getting people to transition to opioid agonist therapy and then have more. The findings are that access and that pathway demonstrates an increased retention on opioid agonist therapy, and I think that's very much in line with what Dr. Henry found in her conversations with clinicians across the province, that the two programs are really working together, and the one is a facilitator and a sort of a gateway, if you will, to OAT.
Member.
Thank you. Thank you, Minister. Honourable Chair, I know the Minister she's aware of the benefits of Naloxone because we've covered this topic not only this year's estimates, but we spoke about it in last year's estimates as well. The only year so far that we've seen a reduction in opioid deaths was in 2019. And the coroner attributed the decrease in the death rate that year to Naloxone becoming more widely available. Since then, we've seen death rates only increase. So to the Minister, why not take action now to make Naloxone kits even more widely available? Why not raise public awareness and increase training and put more kits in more hands in more places in BC by providing both injectable and nasal Naloxone product in every kit? Guidance published by the Canadian Medical Association Journal recommended, quote, take-home Naloxone program should offer the choice of both intramuscular and intranasal formulations of Naloxone in take-home Naloxone kits. Does the Minister intend to act on this recommendation, and if not, why?
Minister.
Thanks, Chair. With respect to naloxone, just to clarify that the findings, both from the coroner and from public health, around the dramatic reduction in mortality in 2019 certainly is ascribed in part to the provision of naloxone. But as public health has clarified, it really is about that, also the sort of suite of harm reduction services that was stood up after the establishment of this ministry. Overdose prevention sites, the anti-stigma campaign. There were a number of components to contribute to the progress that we were making in the period prior to COVID. With respect to intranasal naloxone, there are a number of agencies and areas in British Columbia that use intranasal naloxone, including the RCMP, municipal force officers, TransLink police, and correctional officers, in addition to wide availability through the First Nations Health Authority for First Nations. There, I will say, is a very robust program through toward the heart that has been sort of stood up by the BC CDC. They work in conjunction with health authorities. And naloxone is widely available. There, frankly, is there's no barrier to providing more naloxone if more naloxone is needed in a particular area or for a particular population. Absolutely, that will be provided. We work very closely with the construction industry, for example, through their Tailgate Toolkit project, to ensure that that the work that they are doing with workers in the trades, that they have access to naloxone. We have naloxone available in community pharmacies, in corrections facilities, in obviously across First Nations, in hospitals. Really, any workplace who wanted to have a program to have naloxone provided. And I hear from time to time of workplaces who do want to run training, which they can coordinate through toward the heart. Or through, in some cases, folks at overdose prevention sites. In my community, for the folks at the overdose prevention sites will provide community training and do on a regular basis. Those services are really broadly available.
Member.
Thank you, Honourable Chair. So I understand that the Prince George Citizen today has published a story that's based on a meeting that happened in the community last night. It's called Crime Report Shows Lower Mainland Gangs Making City More Violent. And I'd like to read for the Minister a bit of a statement made by Superintendent Sean Wright of the Prince George RCMP. And it's under the header, Increased Trafficking Linked to Decriminalization of Hard Drugs. Wright expressed his frustration over the decriminalization of hard drugs by the BC government a year ago, which he says has handcuffed police, now powerless to stop drug use in schoolyards, playgrounds, and in the front entrances of stores, and businesses. He considers that by far the largest paradigm shift I've seen in policing in nearly 30 years. It seems ironic that we're vilifying cigarettes to the extent we do, but we're increasing the availability of smoking, methamphetamine, and opioids in public, he said. Drug use and mental health issues directly contribute to a significant amount of criminal offenses, particularly violent offenses. We've noticed an increase in a lot of drug trafficking to support the open drug use. He said at one point half the residents of the former Knights Inn downtown motel, which serves as a homeless residence, were associated with selling drugs. The BC laws were changed to allow government-funded safer supply medications obtained by prescription as an alternative to illicit drugs in an attempt to reduce the number of opioid overdose deaths. But Rappel said in the past year since decriminalization, drug deaths have increased 5%. The year previous, we would have interdicted in some of these instances and taken away the drugs because it's illegal, Rappel said. We wouldn't have charged and haven't charged in a long time. But it's an open question as to whether or not all of those no-case seizures were taking away fatal doses of street drugs that now are not. This is only an excerpt from the article today. My question through you, Chair, to the Minister is this level of detailed feedback being captured in the quarterly reporting done by this ministry to the federal government?
Minister.
Thank you, Chair. I haven't had an opportunity to read the article yet, but thank you to the member for pointing it out, and I'll certainly have staff find it for me, and I will give it a read. The one quote that I understand that the member read seems to suggest that somehow illicit drugs are permissible on schoolyards and playgrounds, and that is that's clearly incorrect, incorrect on its face. The Health Canada exemption specifically prohibits the possession of illicit drugs on K-12 school grounds, childcare facilities, on a number of federally regulated transportation environments. We went back to Health Canada and in fact had a number of other areas added to the exemption. So just to be very, very clear with respect to where the Controlled Drugs and Substances Act continues to apply, that is on K-12 school grounds, licensed child care facilities, federally regulated transportation environments, within 15 millimeters of playgrounds, spray parks and wading pools, and skate parks. So perhaps the officer who was quoted in the article is not taken the education yet or is not clear about how the exemption works, and we will certainly contact the detachment to ensure that that information is provided to that officer, so that officer is clear about where the CDSA continues to, very clearly continues to apply. And with respect to, the issue about what kind of data are we collecting regarding drug seizures, and indeed we are collecting after a very intensive process with law enforcement to negotiate information sharing agreements. We are reporting on possession-related offenses and drug seizure-related offenses. And what we have found is that from the period from February to July, there was a 76% decrease in possession-related offenses, a 95% decrease in possession-related drug seizures under the 2.5 gram threshold, an 83% decrease in possession-related seizures overall. So that's the data that both the government and the police agree is the data to be reported. That's what we reported to Health Canada in our quarterly reporting. And we have, through our law enforcement working group, which is a subgroup of our core planning table, again, a venue where we work very closely with law enforcement. And I would expect that if there are particular concerns in a particular community from law enforcement about how something is working, that would be elevated to senior leadership and would arise in that forum. There's a clear forum where we are very engaged on a regular basis with law enforcement and very willing to have conversations about their experience on the ground. Indeed, that also applies to our work with the BC Association of Chiefs of Police.
Member.
Thank you, Chair, and thank you, Minister. So the Ministry has developed the education and works closely with law enforcement to advise police on, on how they'll conduct their business with regard to the public use of illicit drugs. I'm just wondering, because the Ministry is providing this education and direction to police, essentially, so in the areas described by the Minister as no longer falling under the exemption, so playgrounds, parks, doorways of businesses, and those that were updated as no longer being exempt in September when those changes were made September of 2023. In these cases, are police being encouraged to make arrests under the Controlled Drugs and Substances Act or told to not make arrests under the Controlled Drugs and Substances Act? And are charges being recommended under the Controlled Drugs and Substances Act currently in BC in these described areas?
Minister.
Thank you, Chair. With respect to the education that law enforcement is receiving, that is a co-determined, sort of co-developed webinar in 2 phases that law enforcement agencies signed off on all of the content. They are very present in and part of the visuals and the narration and such that officers are viewing when they take the education. Many municipal policing agencies have made this training mandatory, and data on completion rates is currently monitored by the PSSG. I will just say, with respect to the application of the Controlled Drugs and Substances Act, I mean, the law is the law, and we expect law enforcement to enforce the law and certainly don't instruct them otherwise.
Member.
Thank you, Honourable Chair. Since the changes to the exemption in September of 2023, has there been an increase in number of arrests or charges under the CDSA in the newly described areas?
Minister.
Thank you, Chair. So the data that we are tracking relates to simple possession, and it doesn't include the location of where arrests are being made for simple possession. We'll say that our primary interest in the data that we are collecting with respect to decrim has to do with how we are able to connect people to care. So that is our. Am I okay to continue?
Yes, ma'am, sorry.
Yeah. So that is the primary focus of the data that we are collecting. It may be that PSSG has more information or could advise on how to provide more information with a more granular level of detail. So I would just defer that question on the location to them.
Okay, at this moment, I'm going to call a 5-minute recess for everybody to get a stretch and so on. I call the committee back to order at this time. Thank you to everybody for being so prompt and getting back. Member.
Chair. So as part of the work being done by the UBCM Catalyst Research Survey, elected local officials and senior government staff were invited to provide feedback. Here's some of the examples of information the government's seeking to extract from that survey. 1 year into the pilot, and after they failed to provide a monthly dashboard that was required for exemption to proceed. Business and public complaints. If their local government is conducting any research or collecting evidence of the impacts of decriminalization, and if they are collecting data on public drug use or complaints. So the question to the minister is, isn't this data that the ministry that it's seeking now, that after months of public discord, isn't this the exact type of data that should have been collected and publicly disclosed in a monthly dashboard? And why are you now seeking to piggyback off any possible work that local governments may or may not have done? And why wasn't this framework and data collection started beginning January 31st, 2023?
Minister.
Thank you, Chair. Just again to clarify for the record that with respect to the monthly dashboard, the requirement from Health Canada is a quarterly dashboard. That's what we've worked through with them, given that it is, given in the early days of the decriminalization project, it became very apparent that collecting the data and allowing to, just the process of data collection from the various agencies wasn't really practical to do that on a monthly basis, and the parties have all agreed that a quarterly data snapshot meets the requirements of the exemption. We have of course been working with municipalities since in the lead up to decriminalization. The Union of BC Municipalities has been very much part of the process. They're on the core table. They're on our local government working group. So, of course, we've been very involved, and we hear directly from municipalities. I've met with many municipalities over the course of the last year. The purpose of having a third-party evaluation is so that we have an arm's length evaluator collecting information in a different way than we are hearing it from municipalities on a regular basis. It's one part of kind of a multi-pronged monitoring and evaluation process, and it's helpful. It will be helpful, and those questions are going to be helpful, in part to again collect rigorous, both qualitative and quantitative data from the ground, not so that we can piggyback off of what so much off of what municipalities are doing, but so that we can understand what municipalities are experiencing, and so we can ensure that the work that we do reflects what their needs are. For example, I understand that there was a presentation made to Prince George City Council last night by the RCMP, and that presentation showed an increase in intoxication and consumption of drugs in public spaces over last year, but there is still a dramatic reduction of that when compared with 2020. So what does that mean? It will be very helpful for us to understand and have a process for Prince George to explain, to share with us what they think that means, how that impacts this project, and how their experience and the experience of other municipalities across the province, are feeding into how we make changes to decriminalization as we go along.
Member.
Thank you, Honourable Chair. As the Minister knows, there have been serious allegations of anti-Semitism in the BC Public Services and the government. Can the Minister discuss what she's doing in her ministry to combat anti-Semitism, to ensure the Jewish community members who require mental health and addiction support are able to access services safely and without stigma?
Minister.
Thank you, Chair. I think that as the member is aware, throughout the public service, there are a number of programs, a number of required trainings for public servants relating to respectful workplace, psychological health and safety in the workplace, anti-racism, diversity, equity, and inclusion essentials, as well as a process for identifying and addressing any concerns that may arise under any of those areas. In terms of the work of the ministry and the Jewish community, the ministry was in the process of initiating discussions with Jewish service organizations to host a roundtable in the early fall, and we very much look forward to being able to resume that work at an appropriate time. I also understand that Vancouver Coastal Health, through our community counseling grants, there is a community counseling grant that's gone to Jewish Family Services. There would be a number of community counseling grants that would be sort of distributed to different service providers across the province, serving different populations.
Member.
Thank you, Chair. Thank you for that, Minister. So the Minister may be aware that in the past 5 years, the organization Vandu has received almost $4 million in funds through Vancouver Coastal Health. Is the Minister aware that, according to a post in November, that Vandu's Tuesday Education and Action Group has hosted weekly workshops on the ongoing occupation and genocide of Palestine and the history of resistance? I'm going to pass the Minister some social media posts, if I might, from Vandu. The Minister has said that there are legal requirements for organizations to use their funds outlined in contracts, with the expectation requirement, frankly, for organizations to use the funds that they received in the way they're intended for and outlined in contracts. Does their inclusion and anti-racism policy and expectations, does it extend to contract partners and nonprofit organizations who get funding? I'll remind the Minister that the Premier has been on record about his desire to root out anti-Semitism in the public service. Is the Minister aware of how these activities may be yet another barrier for the Jewish community members who are trying to access services from this government? And what is the response from the Minister?
Oh, Minister, my apologies.
Thank you, Chair. Just before I answer, I mean, I'll get an answer for the member, but just to say, I can't read this. They're very small. So if the member is able to provide the URL to this or a larger copy, that would be very helpful. Thank you.
Minister.
Thanks, Chair. As I said, I'm happy to receive a copy of the material to understand what has prompted the concern from the member. I will say that, we are not in control of what groups do with donations that they may receive from other sources or what they do in their off time. Vandu is contracted to provide overdose prevention services, to provide education. They have been for many, many years under successive governments. That's what they're doing with the funds that they are receiving from Vancouver Coastal. And I'm happy to follow up on any other concerns that the member has.
Member.
Thank you, Minister. And I will follow up by sending the URLs for the posts from formerly Twitter, now X, for the Minister to review. So the tweet or post, whatever you call them now, from this platform, it says that this is the activity of the Education Action Group. So this is part of the education that is being provided by this government partner. It has hashtag Free Palestine. This is in the days very shortly following the horrific attacks on October 7th. The minister states, Honourable Chair, that the government has no control over what its partners say and do in their off time. But does this not raise the concern, given that there are right now questions about anti-Semitism, not only within the caucus of the government, but within the larger public service? And, the question really is, are these activities with respect to education being provided by and funded by this government, are these activities in line with the expectations of this government and this ministry?
Minister.
Thank you, Chair. And I do want to again be clear with the member that anti-Semitism is not acceptable. Any form of hate is not acceptable within the public service, within government, within our communities. And our government is committed to fighting hate wherever we find it and to supporting groups who are feeling the impact of hate. Vandu is not funded, does not receive funding to run the education group that the member has referred to. And again, I'm at a bit of a disadvantage here because I can't actually see the material that the member has forwarded. Vandu is funded in order to provide education related to harm reduction, related to health promotion and peer education. They provide also services with respect to access for indigenous people to health services on the downtown east side. That's the work that is done with Vandu. And I want to say again that we want people who are feeling the impact of global conflict right now to feel like they can reach out to health services, that they can reach out to government and get the support that they need. And we are working to ensure that that is the case.
Member.
Thank you, Chair. If after a review of the information I provide to the government, if this government and ministry finds out that their partner, Vandu, is spreading anti-Semitism or hate, will the government stop its funding?
Minister, thank you.
Thank you, Chair. I would just say again that we, have no tolerance for hate. We have processes inside government. We have a Human Rights Commission. We have an entire government team that is dedicated to human rights. And it is, in fact, the reason why many of us ran and got involved in doing this work, is to protect and promote human rights. And that is the work that we will continue to do.
Member.
Thank you, Chair. What funding did the Drug User Liberation Front receive from the government in the past fiscal year, including funding via Vancouver Coastal Health? And there's several parts of this. It's A, after the contract was terminated, following the revelations that DULF had blatant illegal activities in purchasing and trafficking drugs from the dark web. How much funding had the organization received in total for the fiscal year 23-24? Was the money provided in full prior to the contract cancellation? Was the money recouped following the contract cancellation? Were any funds that were previously allocated to DULF, were there any previously allocated to DULF, were they recouped in any way?
Minister.
So I'm sorry, member, can you just repeat the last one?
Member.
Just if any of the previous funds, Chair, if any of the funds that were allocated to DULF have been recouped on behalf of the public in any way?
Minister.
Thank you, Chair. We're just verifying the start date for the contract, but my understanding is that it was, that they received a full year of funding for the fiscal year 22-23. They also received funding for 23-24. That contract was terminated effective October 31st, 2023, and there was no further funding after October 31st, 2023.
Minister. Sorry, my apologies. Member.
Thank you. I knew that you meant me, but didn't want to be disrespectful. Minister, are you able to clarify, so was the entire amount for the year awarded prior to October when the contract was ended, or was there still some money that would have been paid?
Minister.
Okay, thank you, Chair. No, they would not. They were on a monthly payment system, a monthly electronic transfer system, which is the standard protocol in Vancouver Coastal. So there should not have been anything left outstanding after October 31st, 2023.
Member.
Okay, thank you very much. Thank you, Chair. If possible, we do want to have the total that was paid out for the year when that's located. In the meantime, I'll move on to my next question, Chair, which is if the minister can confirm how much funding the ministry's provided to the Community Action Initiative over the past 3 fiscal years by each year. And can the minister also confirm how much of that funding was to support what's called a provincial peer network grant?
Minister.
Thank you, Chair, and welcome to the Chair. For the year 2023-24 to 24-25, CAI will receive $4.926 million annually to support the community action teams and the provincial peer network. There's a $2 million annual investment committed over that period to support the provincial peer network with stable funding. There is also, if the member is interested in the sort of historical, we'll have to go back and get that. We don't have prior year spending in the binders, so let me know if you'd like that, and we can go back and get that for CAI. CAI is also, since 2018-2019, CAI has provided a total of $35 million to support the Community Counseling Grant Program. They're the vehicle that organizes that program for us.
Member.
Thank you, Chair. Were any other grants or funding sources issued to the Drug User Liberation Front via the Community Action Initiative?
Minister.
Thank you, Chair. The answer is that yes, we did. There was a grant to DULF under CAI, and we're just trying to pull the details of that for the member.
Member.
Thanks. Just to add to that, Minister, please, if I could have the dates of that funding, when that funding would have concluded. And what I essentially want to know is, did that funding actually continue after the other one?
Minister.
Yeah, we're just tracking back, and so we'll provide that information.
Up to you, member. Go ahead.
I'll ask another question, sure.
Member, go ahead.
Thank you. So in a Q&A session of the Australian Injecting and Illegal Drug Users Stigma Conference that was live streamed on November 16th, 2022, one of the co-founders of the Drug User Liberation Front, Jeremy Callicum, stated, quote, "We tell everyone everything we do." That's the end of that quote. The other founder, Eris Nix, stated, quote, "The problem has gotten so bad that our health authority has moved in and offered their support and limited funding," end quote. While Jeremy Callicum claimed they can't use any of that money to buy drugs and claimed that no laundering was taking place, Eris Nix openly mocked this and made insinuations that laundry was of some kind was indeed being done. What actions has the minister taken to ensure that no money laundering of any kind took place in order to facilitate the purchase of illegal drugs from the dark web.
Minister.
Thanks very much, Chair. And while I can't speak to the tone that was used or the words spoken at an international conference, what I can tell you is that I would find it appalling and completely irresponsible for partner organizations to behave in that way. That's not acceptable to the ministry. It's not acceptable to our government. And further to concerns that were raised on this topic last fall, the Deputy Minister for the Ministry sent a letter to all peer groups, all organizations that we partner with, to be very clear about what our expectations are with respect to the delivery of the services that they are contracted for, and to be very clear that we will not support organizations who engage in illegal activity.
Member.
Thank you, Honourable Chair. Thank you, Minister. I do appreciate that that letter was sent out. I think it's important for the government to ensure that taxpayer dollars are used legally and, of course, ethically. But, you know, the fact that an organization that had received government funding, by our estimate, at least 140,000 taxpayer dollars over 2 years, what actions were taken after these issues were raised to investigate whether there was, in fact, any laundering of public money or conversion of that money into cryptocurrency, and that it was not being used. Public money, what did you do to ensure public money was not being used to make drugs or purchases of drugs, rather, on the dark web?
Minister.
Thank you, Chair. Just to prompt everyone's memory about this situation, the organization in question was contracted to provide overdose prevention and drug checking services. Reports on their drug checking were certainly submitted to the Vancouver Coastal Health Authority, and I mean, it is the reality that the individuals who are using services of overdose prevention sites are, in fact, using drugs procured from the illicit supply. But the services that the organization was contracted for are the services that were delivered. And again, we can't speak to what they were doing with other funding that they received from other sources, and that all remains under investigation with the Vancouver Police Department.
Member.
Thank you, Chair. It did come forward that the contracted services were for drug checking, and then it was made clear that there was other activity taking place, that this is an organization that openly jested, openly spoke at a conference, that it had converted money to cryptocurrency, that it was doing, these are their words, laundry, that laundry was going on so that they could purchase drugs from the dark web. So when it became clear to this government and to the minister that there was a potential that public funds had been used to purchase illicit drugs from the dark web by an organization that was receiving government funding, did the minister order a forensic audit? And if not, why did you feel it was not necessary to call for an audit, given the potential that public funds were used to commit illegal activity?
Minister.
Thank you, Chair. Again, the services that DULF was contracted for were to provide overdose prevention services and drug checking services. Those services were delivered. When it became clear that there had been illegal activity on the part of the partner, the contract was terminated. No further money flowed to the organization. There was no basis for any further investigation. The police are now in receipt of all of that material and are investigating the activities of the organization. And our government, our premier, have made it very, very clear that illegal activity on the part of our partners will not be tolerated. That message has been distributed across all of our partner groups, and we trust that will be complied with.
Member.
Thank you, Chair. Does this apply to organizations funded, for example, for research? If they partner with organizations that are involved in criminal activity. So, for example, the BC Centre on Substance Use has partnered with the Drug User Liberation Front to conduct their research. The government continues to fund that organization, of course, because it's a research organization. So how does this, situation where we have now a research organization funded by the government continuing its engagement with an organization that has been engaged in illegal activity and, as far as we know, continues to engage in that activity? Does this same, rationale extend to those that are being funded that continue to partner with organizations that are breaking the law.
Minister.
Thank you, Chair. First, just let me clarify the nature of the relationship between the ministry and the BCCSU. As a sort of a clinical practice group, the BCCSU is responsible, and the work that government funds through BCCSU is the clinical work related to their work on particularly opioid use disorder. So the opioid use, developing clinical guidelines, providing education to professionals, providing fellowships for addictions medicine physicians who are working in this space. Research that may be conducted by affiliates is a separate issue, and clinicians who may also have a research role, for example, with a post-secondary organization, may well undertake research that is funded completely separately from the work that excuse me, undertake research that is funded completely separately from funding that government is providing for the frontline clinical work. And it is my understanding that the research study that I think the member may be asking about was in fact provided through a grant from the Canadian Institute for Health Research Foundation. It was a Canadian Institute for Health Research Foundation grant, which has nothing to do with the BC government.
Member.
Thank you. So given that there is a potential that government funds, or public funds rather, were used in the commission of a crime. What protocols are in place by this government? What has been changed in light of this situation to ensure that this doesn't happen again and to ensure that the public funds are safeguarded from criminal activity?
Minister.
Thank you, Chair. Yesterday we canvassed, I think, quite extensively the provisions that health authorities have in place, that the ministry has in place with respect to contracts, to the deliverables, to the schedule of payments and the schedule of deliverables that are outlined in Schedule A of contracts. And again, I would reiterate in this case, it is not our view, not our position at all, that public funds were used inappropriately. Public funds in this case were used to provide services that were very much needed services, particularly in the neighborhood in which they were provided, given that that is the neighborhood that experiences the highest mortality due to toxic drug poisoning across the province. Contract deliverables, whether it is a contract that ministry holds with an operator or whether it's a health authority, are reviewed on a regular basis. The ministry meets with health authorities on a regular basis to review the work that is being done under that we have contracted for. Each health authority, in fact, has contract management departments that are responsible for overseeing their contracts. And in order to be absolutely crystal clear about our expectations, again, we've communicated with all of our partners our zero tolerance approach to illegal activity.
Member.
Thank you. So, Minister, you just stated that you feel very confident that all the money in the contract that was provided to the Drug User Liberation Front was used for drug checking. You know, I think our estimation was it was around $430,000, and I think that the DULF program was checking drugs for about 43 people. Seems kind of expensive, but so what did you do to verify? So, you know, or the health authority, how did they verify that all the funds were used for that? And then regardless of the funding, just a part two, regardless of whether or not BCCSU received funding directly related to DULF, does it concern this minister or this government if its primary research partner is engaging with groups engaged in criminal activity? And for example, this time it was with the Drug User Liberation Front, but if they decided to pair with the Hells Angels, another organization that also deals drugs, would that change the scenario?
Minister.
Thank you, Chair. With respect to, again, the work undertaken in this contract, the bulk of the amounts would have been for staffing the overdose prevention site, including not only staff, but including peer honoraria and funding for the Indigenous peer support group, given the disproportionate impact on Indigenous people of the toxic drug crisis, particularly in that community. And again, that is, that is work that, was seen, was evident by Vancouver Coastal. When it comes to research, of course, we're concerned about the veracity and the origin of research that is done. And there are many independent researchers and, researchers affiliated with universities who do undertake research in many areas of illicit activity, whether it's related to drugs or whether it's related to sex work or related to other broad, activity that that kind of would be encompassed by the study of criminology. And thank goodness there are independent researchers out there who are helping to inform this area of study so that we can better understand in this particular case the nature of the toxic drug crisis and what we might do to better support people so they're not dying in the order of 2,539 people last year. So the independent, the process of independent research and academic freedom is something that, I think those are principles that are really important, particularly when it comes to health research. That was undertaken in this case.
Member.
Thank you, Chair. I'm going to hand over the questioning at this point to the member from Skeena, who has a couple of budget-related questions for the minister.
Member for Skeena.
Thank you, Mr. Speaker, and thank you, Minister, for taking the time for the questions. The Northwest First Nations Alliance, they formed a coalition to actually help out with the addictions crisis, along with the deaths and the overdoses. They formed their coalition back in 2020, and they submitted a proposal to this government to actually buy a piece of property with a ready-made building on it with rooms and beds, and their proposal was complete with the idea that they could start treating patients within 3 months. Their first proposal was rejected by this government. Representatives of the coalition came down, the Gitxaala Deputy Chief Brenna Innes and Arthur Renwick, Deputy Chief of Haisla at the time. They came down here and they came to I believe it was the throne speech, and they brought copies of the proposal to the reception downstairs later after the speech, and it was my understanding that their proposal was received very well, and there was going to be movement to start basically funding, I believe the minimum, $20 million for the property itself. The coalition is made up of Haisla, mostly out of Skeena, Haisla, Kitsilas, Kitsim-Kalem, and the four Niska bands, Gitwak Damix, Gitwansok, Lakozap, and Gingoloth. But they also have some North Coast First Nations in there as well. They got Gitnyao, and they've also got Gitxaala. But it's gone quiet. And I haven't heard anything definitive in terms of what the next steps are, because I was under the assumption that BC had formed some type of partnership with this coalition, and the property was going to be purchased, and now the only thing left to do was the responsibility of the services being provided, whether it be mobile or at the facility itself. Can I get an update on where this initiative is at?
Minister.
Thank you, Chair, and welcome to the member, and I thank the member for the question. Yeah, indeed, I remember very well the moment down in the reception after the throne speech when leaders from the Northwest Alliance approached me and gave me a copy of their proposal, and that initiated a process that has been, I think, resulted in the development of a really important partnership. And rich learning on certainly our side and on the side of the Health Authority with respect to the critical importance of standing up culturally based services. So I'll just run through the activities of that relate to this work over the last year, because we've been meeting on a regular basis with the Northwest Alliance. In fact, following that discussion after the throne speech, they came down and met with me in my office here in Victoria. That resulted in the establishment of a working group comprised of the Northwest Alliance, the First Nations Health Authority, the Northern Health Authority, our ministry, and we secured in sort of late summer, early fall, the assistance of Dan George as a facilitator for this group to help keep the work moving forward. The group also came down and met with myself and the Premier in the summer again to discuss the ways of moving the proposal forward. I do want to say and really want to thank the work of the Alliance for one of the really important sort of first transformative policies that's been put in place with the Northern Health Authority, and that is transportation policies that provide a much better and safer quality care to individuals who are traveling from Terrace and from the West Coast into Prince George for detox services. There have been some significant policies enacted to ensure that people are safe on that journey, that they can have peer family support or a support person with them. And there are processes now in place that did not exist before to ensure that along that very long journey that far too many people have to take into Prince George, that there is the ability to bring in clinical support over the course of that journey if that's required. So Northern Health Authority has been working with the Northwest Alliance on the ground to remove barriers in that regard. The working group has identified a series of priorities, and the first priority has been the establishment of detox services, bed-based detox services that are medically supervised in the Terrace area, and we are currently in the process of procuring space for those services. And in the meantime, while we are kind of engaged in that procurement process, we want to ensure that there's better access specifically to detox services for folks from the Northwest. So we've worked with Cedars at Cobble Hill to secure some beds through our CMHA bed allotment that will be dedicated to people from the Northwest so that we can provide folks with direct access. We're also working with the group on how we can, in the short term, utilize other facilities as a result of the redevelopment of Mills Memorial Hospital in Terrace for support in the short term. Again, while we are working through issues related to the procurement of bricks and mortar space for services that we know are really desperately needed in that area. I do want to say as well that, this partnership has resulted in, and the work as well that Dan George has been doing related to this group has really resulted in a sort of a culture-first model for detox services, which is frankly going to have a huge impact on strengthening services for First Nations and Indigenous people across the province. It is some very remarkable work that has been undertaken, and I'm very grateful to the work of the working group.
Member.
Thank you, Chair. The whole point of this proposal was to get a treatment center in Terrace so people wouldn't have to travel to Prince George. I believe the minister said there will be a transportation method to bring patients to Cobble Hill. That's on the island. Just doing some simple math, that's much farther than Prince George. That was not where I expected this to go. I thought there was some work being done on the ground to get this facility purchased. But now I hear the minister talking about procuring a space. The space was in the proposal. There was a piece of property up beside the Skeena River that these First Nations selected so they could get the First Nations and non-First Nations away from the streets of Terrace. And why this is important, because First Nations and non-First Nation entities in Terrace right now are talking about transition houses in Terrace. So when they come out of primary treatment, they don't have to go back to their own environments. But there is no primary treatment. And from what I understand, this proposal is not even in the budget. Unless it's hidden someplace else that I haven't seen. Maybe you forwarded more funds to the Northern Health Authority for the purchase of this property. I'm not sure. But I think the direct question is now, given all this I've just heard, is that this will not be funded this year. The specific purchase of the property and the staffing of it that the First Nations Coalition promised that they'd provide in partnership with the Native Health Authority. So before I turn this back over to the member from Surrey South, I don't even know if this question is even relevant anymore. What is the timeline for this proposal? Because every First Nation is experiencing deaths, family and friends. And I thought this was a crisis. I thought it was urgent. I mean, we see all the First Nations now are declaring states of emergency. Port Hardy. I'm burying family and friends as I speak. So what is the timeline? And if it is not going to be the purchase of this property as put forward by the First Nations, what is the plan apart from transporting First Nations and non-First Nations who are suffering from substance abuse to Cobble Hill and Prince George? What are we talking about here in terms of timeline? And are we really talking about a possibility of another budget after the election? Is that what we're really talking about?
Minister.
Thank you, Chair. And thank you for the member, I mean, for his advocacy with respect to the services that we know that people, and particularly Indigenous people across the Northwest, very much require. We have been in, again, a process with the Alliance, with the working group, with the Alliance, the First Nations Health Authority, the Northern Health Authority, and the Ministry to ensure that while we are working through the proposal and their desire with respect to the property they've identified for the treatment part of the proposal, which we have said to the Northwest Alliance we are going to fund. We support it. We're working through a process right now to get to that point. But there is an urgent need, as the member identified. There is a terrifically urgent need now to ensure that people who require, First Nations people who require services get them now, which is why for the short term, we're going to be continuing to rely on services in Prince George while we are standing up bed-based detox, access to bed-based detox in Terrace, which is on the way. We've also co-developed with the Alliance and with the First Nations Health Authority new access to a new mobile outpatient detox service plan, which will provide outreach to communities to support people be able to access additional services. And in the interim, just as an immediate stopgap measure for what I hope to be a very short period of time, we've procured some other beds so that if somebody needs detox right away, they can access it without having to wait. Again, very grateful for the work of the working group, and in particular Dan George for pulling the parties together to work out what is a comprehensive plan to be able to provide the services in the short term and the long term that folks in the Northwest are needing.
Member for Surrey South.
Thank you, Chair. Following up on last year's estimates and the revelation that only 60% of the promised beds were expected to be operational by year-end 2023, what is the current status of the total number of beds, and separately also of 51 beds that were in the contracted and startup phase at that time? How many of those beds have now become operational?
Member wants to finish the
Oh,
question?
I just want to clarify that I'm referring to youth beds.
Thank you. Minister.
Thank you, Chair. So at this point, we have 52 beds of that announcement implemented, an additional 28 that I just announced earlier this week, which will be, or last week, that will be open by June of this year, and a further 16 to 21 that we anticipate will be open this summer. So that'll bring us up to approximately 100 by the summer of 2024. I think I would just, want to take a moment just to note, a similar discussion, I believe, that we had last year with respect to bed-based youth services and some of the challenges that that health authorities have in contracting for beds in this area, in part due to what is often a higher level of care required, but also just more complexities with youth when it comes to what are the right kinds of services. And what I increasingly hear from child and youth mental health experts is that there are a number of other community-based services that are important to provide care to youth, and that in many cases are more appropriate than bed-based services. So this is a discussion that we're having as we work with experts to develop the youth substance use framework, so that we are investing in the right kind of service in the right sort of place for youth.
Member.
Thank you, Chair. The language in Budget 2024 is very specific. It says the $215 million is to sustain addictions treatment and recovery programs currently operating or being implemented. Yesterday, in discussing the 10 million envelope within that 215 million portion, the minister stated, quote, "The 10 million is actually not an additional amount. It's money that reflects what the ministry was accessing through contingencies, which is now built into the ministry's base budget. Can the minister confirm, of the remaining funding envelopes, how many of these were also previously funded out of contingencies?"
Minister.
Yeah, sorry, can I just get some clarification from the member with respect to the particular funding envelopes she's looking to understand?
Well, that's...
Member.
Sorry, thank you, Chair. Sorry, that's the sort of, I guess that's what my, hold on a sec. So, $117 million to continue funding over 2,200 mental health and substance use treatment beds at over 300 health authorities, $49 million to support existing harm reduction initiatives at 49 overdose prevention sites through the province drug checking and naloxone kit distribution, $39 million to provide continued funding for existing peer assisted care teams and mobile integrated crisis response teams, and $10 million to support ongoing policy development and implementation for treatment and recovery programs. Of those, which of those were also previously funded by contingency?
Minister.
Thank you, Chair. So just to go through the item, the allocations that the member identified, and starting at the top with the 117 million to continue funding to more than 2,200 community mental health and substance use treatment beds across 300 health authority and community care facilities. That is new money. That is brand new money that reflects work that was done with community partners and with health authorities to identify budget pressures across those service providers and ensure that we could stabilize those beds, ensure that we didn't lose any of those beds as a result of inflationary pressures and such. So that is completely new money that supports that portion of beds that were identified to be at risk of given funding pressures. The 49 million to support existing harm reduction initiatives at 49 overdose prevention sites, as well as drug checking and the Naloxone kit distribution. That is new money that builds on base money in health authorities to provide overdose prevention sites, Naloxone kits, and drug checking. The 39 million for peer assisted care teams is again new money. That is, we originally had 1 year of funding for peer assisted care teams when they were first stood up, and we have now have new money to build those into base budget. The 10 million we canvassed yesterday very thoroughly. That is the 10 million relates to staffing and benefit costs.
Thank you. We'll take a recess for 6 minutes till 4:15, and I'll note that on my clock and call quorum when we come back. Call Committee C back in session, and the minister was finishing a question. So, Minister, you have the floor.
Thank you, Chair. Just again wanted to clarify the breakdown actually of the 117 new money to support the 2,200 community mental health and substance use treatment beds. There's an allocation for the regional health authorities for sustaining contracts that they have with providers, but also very importantly, there's 16.5 million over 3 years to actually increase the per diem daily rates for social development and poverty reduction income and disability assistance clients who are accessing treatment and recovery services. So effective June 1st, 2024, the daily SDPR per diem will increase from $35.90 to $60 for registered bed-based services and $45 to $70 for licensed bed-based services. And this is the second major increase in support and increase in these per diems that we've implemented. In 2019, we increased these per diems, and that had been the first increase in 10 years. So I'm really grateful for the work that's done across this sector to provide care to British Columbians. The final note in the just is around capital investments, and just to say that there are that we have hundreds of millions of dollars allocated to recovery, the expansion of road to recovery across health authorities, which is very much about both creating Access Central, a single point of entry across health authorities, as well as to support treatment and recovery beds, in addition to expanding concurrent disorder care, such as we see at the Redfish Healing Centre.
Member Surrey South.
Thank you, Chair. According to the service plan, wait times for treatment and recovery services have actually increased, but the data is incomplete and likely insufficient. In the service plan, it noted that despite work being done in 2022, Northern Health has only now reported data for January to March 2023. Interior Health reported partial data, and Island Health also reported partial data. Can the minister explain why it's acceptable to base targets and assumptions on incomplete data, and what accountability measures is the minister taking to rectify this failure to provide reliable, complete data?
Minister of Mental Health and Addictions.
Thank you, Chair. This is an important question that the members raised, and I really want to start by, again, just situating the period of time that we are in relation to the COVID-19 global pandemic and the absolutely extraordinary work done by our healthcare system, done by all of our health authorities, by community service providers throughout the kind of acute phase of that pandemic, which taxed our healthcare system, taxed our communities in ways that we had not previously experienced, and of which we are still feeling the impacts and likely will for some time. And all of the health authority who go to work every day through that period have just done remarkable service for British Columbians. And of course, such an experience on a complex system like our healthcare system does leave lasting impacts. And so at the same time as the healthcare system has been managing the COVID-19 pandemic, they've also been responding to the toxic drug crisis, a situation where we've had our health system dealing with a dual public health emergency. And in the midst of that, we want them to also help us implement the first coherent wait time reporting structure for bed-based treatment services in any province in the country. And in fact, we are the first jurisdiction in the country to report wait times for beds. You know, the work that we have done since 2017 is very much entirely focused on transforming those parts of our healthcare system that are responsible for mental health and addictions care so that we truly treat addiction as a healthcare issue. And our health authorities have been doing some very heavy lifting in this regard throughout this period to build the access and to build that system so that British Columbians have access to the care that they need. So what we've been working on with health authorities during this period in order to be able to reflect a sense of wait times in the service plan really has been starting from absolute zero, because we had no data. We had no systems for collecting data when this ministry was stood up. And so we have gone about putting a framework around mental health and substance use care since 2017. And the work with health authorities has been to develop a performance measurement framework so that we can monitor access and to look at service utilization for health authority-funded adult bed-based substance use treatment across the province. We've been implementing performance monitoring reporting from health authorities. And since that reporting began, we've been working to establish effective monitoring processes and to improve data quality. And that is going to be an ongoing sort of iterative process. You don't go from 0 to 100 when it comes to the quality of data, when we haven't been really collecting that data overnight. This is indeed, and as the service plan enumerates, the ministry's approach to these benchmarks is phased and iterative as we enhance data quality, work with partners such as our health authorities, and ensure a thoughtful approach to wait time reduction. It also allows the ministry to refine benchmarks as new investments begin to open up and serve clients and communities across the province. The ministry will continue to assess targets as new data is available and as we make progress in building the system of care. There are a number of issues that make this process complicated. Wait times are complex data to collect and interpret. We have literally hundreds of service providers across the province, and moving to a more standard contracting regime with health authorities has been an important part of ensuring that we are able to collect the same data, so we're comparing apples to apples across across the system. And we find, I think, as other jurisdictions do, that when it comes to wait times, particularly for substance use treatment, that particular kind of care is very different than other kinds of care that we provide in our healthcare system. And we can't quite manage a wait list in quite the same way. Wait times are very impacted by personal readiness to start treatment, the need for longer stabilization periods. Sometimes it's impacted by somebody's release from custody. It's time to travel to services, access to childcare for women who are needing services. So the work on wait times is very much part of a larger integrated approach that we have that is also seeing us scale up outpatient services as well, so that we can serve more people. But I just want to be clear with folks that what we are seeing is that we are serving considerably more people now than we were at this time last year. And that's some of the value in the early data that we're collecting around the numbers of people who are coming through our system.
Member.
So to begin, let me just situate this for the minister. You've had 7 years. 7 years to establish a framework, to ensure that health authorities were all going in, that there would be a goal of setting, getting wait times. And this is a quote from you, Minister, from last year.
Member,
it's absolutely our goal.
You've been referring to you quite a lot.
Okay, that is what the minister said, Chair. Thank you.
I would just say you've said you about 4 times in the last 7 questions, so I'm just cautioning you not to use the word you to go through the chair.
Thanks, Chair. So the minister has said last year, this is absolutely our goal. Given that this data is not available or accurate, and given again, I will situate this for the minister, through you, Chair, that they've had 7 years, Chair. Your government has had 7 years to collect this data.
And you don't
I think it's
refer
time
me
to
as
admit
you.
that this is
Member,
another broken
member,
promise.
Member, if you're addressing the chair, address the chair. But don't refer to me as you.
Unbelievable. The provincial government's own website.
Chair. The legislature.
It is a legislature, and I cannot believe the disrespect that, given the fact that this is a
Member,
government.
you have a question for the minister?
I do, and I have a
Okay,
preamble.
Please go ahead.
Thank you, Chair.
Please go ahead.
Here's my preamble. That I'm doing a job here that actually, over the last 18 months of doing this job, has revealed many faults with the way in which this government is dealing with the opioid crisis, including denying significant problems, unfulfilled promises. And the fact that I would be in this room and be so disrespected for the important work that I'm doing is outrageous. The provincial government's own website on decriminalization highlights Oregon as proof of decriminalization's effectiveness, stating, quote, decriminalization has been implemented in some form in many other jurisdictions, including Portugal, Uruguay, Germany, Lithuania, Australia, the Czech Republic, and Oregon, USA. Available evidence suggests that decriminalization can be an effective way to reduce the harms associated with substance use and criminalization, end quote. What available evidence did the ministry analyze in its preparations ahead of and during the implementation of decriminalization as it relates to Oregon specifically, and now, considering that Oregon
Minister.
Thank you, Chair. With respect to Oregon, I mean, yeah, of course, we're following, we're following developments in Oregon. We're following developments, frankly, in every jurisdiction that has something to offer in this regard, because we just want to learn from what other similar jurisdictions are going through, who are experiencing the same issues related to the volatility of the toxic drug supply and the impact of that on people in our communities. So we're certainly following Oregon. We're following other jurisdictions. At the outset, certainly our team had conversations with folks in Oregon, with service providers, but I think there are some very important distinctions between us and the U.S. generally, just because we have very different healthcare systems, and we have really focused on engaging in this process in a way that connects this project to our healthcare system. What we are doing is building an integrated system of access to care and treatment for where we have no evidence generated about the efficacy of and outcomes of different treatment programs. That's work that we're also doing with our partners in the supportive recovery sector. We need to have this work fully integrated with healthcare. That's been, our approach. That's very different than the approach that other jurisdictions are taking. And with respect to sort of what studies did we look at, I could read them into the record. I won't spend the time doing that, but I certainly have a list of academic studies related to decriminalization and the outcomes of decriminalization in certain jurisdictions that we can provide to the member.
Thank you. These locations, Oregon, Czech Republic, other European countries, to bolster their position on decriminalization. When these other countries are brought up, for example, Portugal is brought up, the government often uses the fact that, Portugal isn't having a fentanyl crisis to say that they don't have to do things similar to Portugal. When I'm asking the government to clarify, why is, their position not changed, basically, if they're using Oregon to bolster their position on decriminalization, and now the minister stands up to say that we're so different from the United States. So why is it, if we're so different, and that our situation is not similar in any way to what's happening in Oregon, USA, then how does the government justify using these locations and their problems to bolster its position on decriminalization?
Minister.
Thank you, Chair. There is such a wide body of international evidence and commentary when it comes to the issue of how to regulate, how to deal with illicit drug use and in general, and decriminalization initiatives in particular. And of course, they all take into account the particular circumstances of the particular jurisdictions. And so it shouldn't. We talk about Portugal. The fact that there is not a fentanyl crisis in continental Europe is absolutely relevant to how frontline addictions medicine physicians treat patients. The fentanyl crisis on the North American continent drives everything around how doctors deal with the physical symptoms and the physical impacts of that molecule, those molecules, on people's bodies. So, of course, there are differences. There are also elements to learn, and we want to make sure that we are learning helpful information about and helpful experiences to help inform our own experience. But at the end of the day, of course, what we did was develop through our core planning table with our partners an arrangement that was really sort of a made in BC arrangement, and that is the project that Health Canada granted the exemptions for. I mean, when it comes to sort of validators for the approach, we've also just recently had a statement from the Royal Society of Canada, urgent and long overdue legal reform and drug decriminalization in Canada. And what they state is that there is a large body of international evidence demonstrating that criminalizing certain activities relating to substance use can deter people who use drugs from seeking help, promote stigma, and increase the risk of HIV, HCV, poisoning, and other negative health outcomes. And it goes on, and I could go on and into the record from the deputy chief of the Vancouver Police Department, Fiona Wilson, who is on our core planning table, who has been a strong proponent of decriminalization, the UBCM statement on decriminalization on January 31st, which said, as BC's decriminalization pilot project reaches the end of its first year, local governments continue to support this initiative as one tool to address the toxic drug crisis. The First Nations Health Authority, recognizing decriminalization is important and necessary step towards removing stigma and humanizing people who use substances and address some of the same harms that affect them, et cetera, et cetera, et cetera. We need to approach this project in the way that we do, as an iterative process where we learn, we make adjustments as we go along. Because in the toolbox that we have to address the toxic drug crisis, we need to do everything that we can, and we need to try innovative solutions. I'll leave it there.
Member.
Thank you, Minister, for entertaining my questions this afternoon. Thank you to the ministry staff for your hard work and finding out the answers that I sought. That is the end of the questions that I have for you. I'm going to turn over the floor to the leader of the third party, who is the MLA for Cowichan Valley. Thank you.
Leader of the third party.
Thank you, Mr. Chair. Happy to have a little bit of time to ask the Minister some questions on her file. I'm just going to pick up on an answer the Minister was just giving about treatment and recovery and the lack of evidence that she talked about. And from that, my first question is, are there steps being taken to move towards regulation of treatment and recovery in this province? We've heard from the coroner, we've heard from a number of concerned people that this is currently an unregulated industry. And that I heard the Minister talk about data collection. Will there be a requirement of data collection from anybody doing any treatment and recovery programs in BC?
Minister.
Thank you, Chair, and welcome to the leader of the third party, and thank you for the question. Yes, just to sort of just to speak a bit about siloed from the rest of our healthcare system. That wasn't really connected in a meaningful way, and we have worked to build a system of access and to bring that sector into the fold, as it were, and into a more structured relationship with health authorities and other healthcare services. So one of the first developments around regulation came in December 2019, where we amended the Community Care and Assisted Living Act and brought in a new assisted living regulation and developed standards where there were none for the regulated supportive recovery sector. Requirements for care planning, for safe transitions for individuals out of care. Required evidence-based approaches, evidence-informed approaches to care, culturally safe and appropriate services. And we have, I've directed the health authorities to ensure that all of those compliance standards are incorporated into the standard contract between health authorities and community service providers. Since those developments, we've also invested in the assisted living registry and added additional staff to the assisted living registry to ensure that we can engage in more direct sector-specific oversight around compliance monitoring, ensuring there are minimum site visits, and that we're really enforcing the regulations under the assisted living registry. Health authorities are in the registry is in the process of hiring those FTEs and deploying those resources in the field. We're also understanding that we need to do more work on the regulatory framework for this sector. We've engaged in a process with the supportive recovery, What We Heard report that is focused on issues related to the data collection and evidence that we want to be gathering from contracted service providers. Also wanting to understand the kinds of issues that service providers experience, whether they are dealing with health authorities on the question of what's the process for an individual identifying they need a service and then getting on a list and getting access to that service, trying to ensure that we're in a position to build out that singular system of access that we're working towards in Road to Recovery. And again, ensuring that we have rigorous adherence to all of the points of compliance that have already been implemented. This work will allow us to be able to report with much more accuracy what's the quality of service, what's the level of service, what are the wait times, how are people accessing the services of different providers, and frankly, that coupled with the investment that we announced today to provide more financial support to operators in this sector is, I think, puts us on the way to the kind of process that we saw a number of years ago with long-term care, where we really built an appropriate framework for that part of our healthcare system, and to really view this sector as part of our healthcare system.
Member.
Thank you, and thanks for that answer. And the minister actually anticipated my follow-up, which is, if it is part of the healthcare system, does the minister believe or see that it should be regulated in the way that other parts of the healthcare system are regulated, i.e. by colleges? And so does the minister have the intention that this would be regulated akin to the way that we regulate the rest of the healthcare system?
Minister.
Thank you, Chair. So the engagement that we are currently conducting with the sector is looking at a number of issues around strengthening oversight, and that one of the things we're hearing quite frequently from operators is that the legislation, the sort of statutory framework for this sector, really was designed for seniors, and then supportive recovery was added to it, and that there are some tensions that mean that that framework doesn't always fit very well. There is, we've identified that there's not that we need more sector cohesion across this sector. That what tends to happen is that providers who provide really great quality care and who have a good reputation and who are really good partners with the health authorities, if we have more of those in spaces sort of bringing along other operators as well, that's a good thing. And so to think of this as a sector, in fact, and to bring along all of those operators is important. And so in that respect, I'm very grateful for the work that the BC Association of the BC Addiction Recovery Association, the work that they do and sort of what they bring to the table, and being able to sort of be a catalyst to help facilitate that work across the sector. We hear a lot about the importance of peers, about the need for more consistency from a licensing perspective, many issues. And I've had a chance to meet with many of these operators. I think about the work that the folks in my community do at Elizabeth Fry, supporting women who are coming out of corrections, and it's pretty remarkable and life-changing work. And anything we can do to better support it is important. But I'd say it's premature to speculate on what that engagement is going to yield. We will have a very robust and thorough report with a really solid sort of state of the environment and landscape from the sector that will inform the next steps that that government will be taking in regard to regulation.
Member.
Thank you, Madam Chair. Welcome to the chair. I just want to follow up a little bit more on this, because I think we can agree this is a population that is extremely marginalized, vulnerable, and we've heard some not so great stories coming out of this sector about people suffering from forms of abuse in treatment centers. And I guess the overarching question for the minister is more of a perhaps philosophical one, but she's acknowledged that this is a form of healthcare, a part of the healthcare system. What role does government need to play in protecting people who are accessing this part of the healthcare system?
Minister.
Thank you, Chair. Welcome to the Chair. I would start by saying that I mean, ensuring the health and safety of people who are receiving care and bed-based services is a key priority, and that's what's really driving all of this work with respect to the regulation of these services. When it comes to health authority contracting in this space for services, there are, of course, specific expectations in the health authority contracts with respect to what the expectations are with respect to operators adhering to the regulations and to the practice standards. We would direct individuals if there is a concern about a particular operator. If they're registered with the Assisted Living Registry, they can go through the Assisted Living Registry in the same way that somebody in that a senior, someone in an assisted living home would use could use the Assisted Living Registry to raise a complaint. The patient quality care process within health authorities for those services that are contracted between a health authority and a provider is also available to individuals who may have concerns about the quality of care received in a facility that is contracting with the health authority. I mean, those are those are ways in which these services are connected to those processes that come from our healthcare system. And I would say that there is much more work to do, which is why we are engaged in this process of sort of regulatory review and what are the next steps that we are taking to ensure that we are improving on the level of service, improving on the evidence and the data that we can collect from operators in order to strengthen our mental health and substance use system in BC.
Member.
Thank you, Madam and Chair, and it's helpful from the Minister. I think I'll not pursue that line of questions anymore, but I'll just say that, we're hearing an enormous amount of conversation, both from government and opposition, around treatment and recovery. This is a self-described growing industry in this province, and as we see public money increasingly being moved into this sector, I think it really is incumbent on government to try to build a foundation that puts protection of people who are accessing these services at the forefront. Because for the most part, these are people who have not been protected by any other services that they've accessed. These are people for whom there have probably been a lot of systemic failures. And I think it's just a really important conversation to be having in an ongoing way about what role government needs to play in regulating and insisting on evidence-based and data-driven treatment programs in this sector. I'm going to just speak specifically. I know there's been a lot of conversation about the toxic drug overdose and safe supply, but just going to throw two questions into one. 77% of toxic drug overdose deaths are men, and Indigenous people are also hugely overrepresented in the deaths that we're seeing. Is the ministry using a gendered approach to tackling drug toxicity deaths, and is there an Indigenous specific and culturally appropriate care
I mean, I guess really just by saying that, yes, the impact of the toxic drug crisis has a vastly disproportionate impact on Indigenous people, in particular on Indigenous women. And it has been our work to sort of segment, if you will, those who are particularly at risk and develop interventions that focus on those populations. With respect to Indigenous and First Nations people, our work is aided by a $171 million investment that was made in the previous budget to stand up treatment centers, access to land-based healing that is really led by Indigenous and First Nations people. We do this work often in conjunction as well with, of course, the First Nations Health Authority, but also regional health authorities as well. We are working directly with a number of nations or coalitions of nations across the province on services in the Northwest, for example, with the Northwest Alliance, which is representative of a number of First Nations across the Northwest. We're working with TNG, the Silkstone National Government, on a project. We work with nations on the island, really throughout the province. The core work that we're doing in the healthcare system to scale up the road to recovery, which is a seamless model of addictions care developed by frontline addictions medicine doctors at Providence Healthcare, is key, has as a key component to it work with the Indigenous Wellness Service at Providence Healthcare. So that perspective and that orientation is built into the very foundation of this approach, and that is the same expectation that we have of other health authorities who, flowing from this budget, will start to work in their own health authorities to scale up that approach. We have a pre-existing funding arrangement with Canada and nations through the First Nations Health Authority to fund Indigenous-led treatment centers. We opened the first one last fall in Duncan at Sultan Laylam, and there are a number of other treatment centers flowing from that project that are led the development $1 million towards the work that they are leading on addressing the social determinants of health. When it comes to the gender and just throughout procurement in our healthcare system, an Indigenous lens and a requirement of an actual demonstration of engagement with local nations is a key part of what health authorities are doing now. We have a very focused project as well with respect to, in particular, men who are working in the trades. We flowing out of a roundtable discussion with the construction sector last August. There are the construction and heavy equipment operating sector that are really key to helping to develop the interventions that are going to work for that sector, given that we know 1 in 20 people who die from toxic drug poisoning are employed in those sectors. And I would just say as well that when it comes to the South Asian community, there are particular impacts on the South Asian community, particularly in the South Fraser, and a lot of work being done with Fraser Health in that regard. We toolkit, we fund the construction projects with the construction industry rehab plan, including their opioid-free pain service, which is a novel innovative service that they have developed and are hoping to scale up to provide to construction workers across the Lower Mainland and eventually across the province. They also have an app that is specific to that sector, that population group that we fund to help connect to just mental health supports generally. So yes, agree. Very, very important to have very targeted interventions for populations, particularly at risk.
All right, thank you. Recognizing the House Leader of the Fourth Party.
Well, thank you very much, Madam Chair. My question through to the Minister is, how many individuals are either addicted to safe supply drugs or being supplied with safe supply drugs in British Columbia?
Minister.
Thank you, Chair, and welcome to the member. There are approximately 101,000 people in British Columbia who are living with opioid use disorder. And of those individuals, there were in the month 553 who were provided a clinical intervention from the Pharmaceutical Alternatives Program.
Member.
Thank you very much, Chair, and I do thank the Minister for the answer. Would the Minister happen to know how many of that 4,553, I believe was the number she said, how many of those individuals were First Nations? Is that tracked?
Minister.
Thank you, Chair. First Nations and Indigenous people in British Columbia are disproportionately impacted by the toxic drug crisis. First Nations people comprise 3.4% of the province's population. They comprise 17.7% of toxic drug poisoning deaths in 2023 and 15.4% of toxic drug poisoning deaths in 2022. The rate of toxic drug poisoning death is as follows. First Nations people died at 6 times the rate of other BC residents in 2023, and this number was 5.3 for the same period in 2022. First Nations women died at a rate of 11.9 times the rate of other female BC residents in 2023, and First Nations men died at a rate of 4.6 times the rate of other male BC residents in 2023. The First Nations Health Authority is the steward of the data with respect to First Nations people, with respect to the prescriptions provided, other healthcare provided. Our healthcare system doesn't disaggregate that data.
Member.
Thank you, Madam Chair, and I can tell from the minister's tone of voice it's very troubling. And I can see the toll it takes upon her. In general, and if need be, the minister is more than welcome to write back these numbers if she wishes. But in general, what are the ages and demographics of the individuals experiencing addiction to the safe drug supply? Do we? And if need be, like I say, I'm more than happy to have that in writing. And while we're looking at that, if individuals' first opiate use was through the Safe Supply program.
Minister.
Thank you, Chair. I just wanted to clarify the member's first question. I understood the second question. I'm not sure I properly understood the first question. If anybody is receiving a clinical intervention from, in the way of a pharmacy for there.
Member.
I'm sorry. Thank you, Madam Chair. Now I'm confused. Was the minister's questions in regards to how many individuals' first opiate use was through Safe Supply? Was that what you were? No, the first one. Okay. In general, what are the ages and demographics of the individuals experiencing addiction through the Safe Supply drugs? So, of the Safe Supply, those that are getting access through the Safe Supply, what are the ages and the demographics of those individuals?
Minister.
Thank you, Speaker. And maybe I'll just go sort of from the, I'll answer the first question first and then just talk a little bit about what we do know about demographics in this space. How many individuals first experienced opioid use came from prescribed alternatives? That would be 0. In order to be eligible for that clinical intervention, an individual is required to actually have a clinical diagnosis of an opioid use disorder. And then when it comes to sort of the, how we understand that universe of 101,000 people in the province who have an opioid use disorder, we think. I think the clearest data around, the clearest demographic data we have is from the coroner's report from the unregulated drug deaths by age group. And again, what that shows us is that it is primarily, young men between the ages of 19 to, primarily 19 to 40, but then really 19 to 59, who are predominantly at risk of death due to the illicit drug supply. And we've talked about the disproportionate reputation of Indigenous and impact on First Nations and Indigenous people. I can offer as well that just in terms of the ages of individuals who were enrolled in the prescribed alternative programs between when it was stood up in March 2020 and January 31st, 2024, that 60% of the people in the program, so this is the 4553 number, 60% of those individuals were between the ages of 40 and 65. 35% were between the ages of 19 and 39, and less than 5% were 65 years of age or older.
Member.
Would the minister, thank you, Madam Speaker, through you to the minister, would the minister please describe the cost that Safe Supply, what the cost is to the province of British Columbia?
Minister.
Thank you, Chair. The budget allocation is $95,800,000 over 3 years to support prescribed alternatives.
Member.
Thank you very much, Madam Chair. And would the minister, through you to the minister, would the minister be so kind as to answer how many Safe Supply vendors are approved by the province of British Columbia? And was that included in the 95,800 that she mentioned? Like how many were they? And is that part of that cost of Safe Supply, or was that just for the drugs? Is the cost of the vendors included in that? Let's call it $100,000, shall we? Approximately $100,000 was over the 3 years, or 95. Pardon, 95 million.
Minister.
Thank you. Just to clarify, can the member just clarify what he means by vendors? Is that prescribers, or is that the drugs themselves or?
Member?
Thank you, through Chair, to the man, the prescribers, the prescribers that are supplying.
Minister?
Thank you, Chair. In December 2023, there were 735 prescribed alternatives prescribers. Those would be physicians and nurse practitioners. And of those, 658 were prescribing an opioid pharmaceutical alternative. The number, the 95 some odd million to fund the program does not include the MSP billing for these practitioners.
Member?
Thank you, Madam Chair. Through to the Minister, if that's the case then, so in addition to the 95 plus million, how much additional fees are being charged? Does she have the number as to what's being paid to the prescribers in its totality?
Minister?
Thank you, Chair. We have to pull that information from health, from the Medicare database. There are essentially, there are the medication costs, there's the fee-for-service costs, and then there are program costs which come out of the 95 million, which may be for those prescribers who are not on a fee-for-service. They may be part of a clinic where there are wraparound services and there may be other staff who are and overhead, et cetera, that may be part of the cost of running those pharmaceutical alternative program in certain areas. But at any rate, we can pull the MSP data.
Thank you for your time, Ms.
Recognizing a member from Penticton.
Thank you, and through yourself, Madam Chair. Minister, just before I hand the reins over to somebody else, just a quick comment. Discovery House in Penticton, they're about to open their fourth business, no, it's not a business, fourth home for people that that are in need of what they provide. We've just lost Jerome Abram. Jerome Abram was a gentleman that was running Discovery House. He did an absolute incredible job. So through the chair, I'm just here, no questions. It's just please keep that entity in mind and have a look at his success rates for taking those off of the street and converting them back and bringing them back to a life that we would all like to ensure that they would have. So Jerome's services are coming up. He passed away of cancer just the last 10 days, not even that, last 5 or 6 days ago. But they are opening their fourth home. So I'm just planting the seed with you. If you and your staff would have a look at Discovery House in Penticton and have a look at their success rate. And I know that they don't get that much from the government. A lot of it's self-finance. So thank you, Madam Chair, just for yourself. And thank you, Minister.
Minister?
Thank you, Chair, and I appreciate that it wasn't a question, but I did just want to express my gratitude to the member for letting me know about Jerome's unfortunate passing, and just to say that I've had an opportunity to visit Discovery House when I was in Penticton, when I was traveling in the interior. I'm sure it was the one in Penticton. And met with the service providers, met some of the clients who were there, and just to say that Discovery House is one of the partners that the Interior Health works with, who will benefit from the per diem increase that we announced this morning. So thank you very much for your advocacy for those services, member.
All right, now we're going to recognize the member for Parksville Qualicum, because we're going to get to the next ministry by the end of the day. Member.
Thank you, Chair. I appreciate the desire to be punctual. They never warn people who are considering becoming MLAs about the impact of hearing from not just strangers, but people you know when they lose their child. I have several people in my community now that I've had that conversation with that I know, and I have had that conversation, that very personal conversation, with probably more than a dozen different parents and siblings. It's a troubling situation, and it in many ways feels like it's getting worse, and I'm not saying this to be critical of government, but we are seeing that. My first question is, when I talk to the mental health providers in my community, one of the barriers that they raise is the length of time it takes for an individual to get into treatment. I'm hearing different numbers in my community, and I guess the first question I'd like to know through the chair to the minister is, in central Vancouver Island, specifically Oceanside, but wherever the data is captured, are wait times captured by this ministry, and if so, what is the current wait time for accessing treatment?
All right, Minister.
Thank you, Chair. We don't have the wait times data that we've been collecting available by local health area network. We have it by health authority. And we will find that for you and provide it. We can provide it for you for the Vancouver Island Health Authority. The wait times in the province last year were 31.25 days to access a treatment bed. That was down in the second quarter of this year to 28.75. And, you know, again, we have a number of additional services that we are in the process of bringing online. We will have close to 100 additional beds across the province launched by the summer of this year as part of the 180 beds that we announced with CMHA earlier this year. And I'm very pleased to note the development in Parksville and the support of the municipality for the establishment of a treatment facility in Parksville, which will provide 19 treatment beds in Parksville, which will greatly help with wait times in that community.
Member.
Thank you, Chair. Yeah, the 19 beds in Parksville, it was a Valentine's Day surprise when the local government realized they were on the hook for $1 million for it, but it is desperately needed in our community. When I talk to local island health providers in my community, they're telling me right now the wait time is 6 months to 8 months, not 31 days. This new facility in Parksville, it is desperately needed, 19 beds, but I want to remind this chamber that that is to serve the entirety of the island north of the Malahat, and likely even those from Victoria. So those 19 beds in an island that has a population of 1 million people thereabouts is not going to have as much impact as if it were just to serve the local community. While people are waiting for treatment, what services are available to those that are on a wait list for residential treatment or detox or both ideally? What services are available in the Central Vancouver Island region that I represent?
Minister.
Thank you, Chair. Numbers that are specific to Parksville that I can provide to the member regard access to opioid agonist therapy. There are 185 individuals receiving OAT therapy in the Parksville Oceanside area, and there are eight prescribers. There are a number of other MHSU services in the area, including substance use integrated teams, which are teams from the health authority that support individuals with all forms of substance use and can bridge the key sort of gaps in services. There are also is access through VHA's mental health and substance use divisions to outpatient services.
Member?
Thank you, Chair. Yeah, MHSU in my community is facing real challenges, especially with youth trying to get services through some of these programs. But okay, so as far as wait times, that's we don't have answers for as far as what services are available. OAT is available. In small communities like mine, though, there are no harm reduction services. There's no overdose prevention site, safe inhalation site, anything like that. What is being done by this ministry to ensure that active drug users are able to use safely in communities like Oceanside, in communities just like this all over the province, smaller communities that don't have these services?
Minister.
Thank you, Chair. The closest drug checking site, for example, would be in one of the neighboring local health areas in Nanaimo, Alberni, Clayquater, the Comox Valley, and I know that those are not necessarily easily accessible to Parksville, and of course the closest fixed overdose prevention site would be in Nanaimo. The Lifeguard app is an important resource, digital resource for individuals who may be using alone that can connect them to emergency services if they experience an incident while they are using. I would say that with respect to working to stand up services in smaller communities where, of course, people are very impacted by the toxic drug crisis. It is a concern, I know, for VHA to ensure that there is sufficient reach and sufficient services, and that, of course, often requires, particularly in the case of standing up harm reduction services, strong coordination and communication with municipal councils, with local advocates and local partners, and I'd be certainly happy to work with the member on how we could move a project in that direction with the support of VHA.
Member.
I guess through the chair, so my understanding is that there are, to confirm that there are no places where people can safely use drugs for themselves, make sure they don't die. The minister has pointed out that they could hop on a bus, take multiple transfers, go to Nanaimo, or they could drive to Nanaimo, which is a 40-minute drive away from our downtown cores to the overdose prevention site. I appreciate that there are barriers with local governments. I appreciate that there are barriers with Island Health, but at a certain point, if the science is telling us that we need to do something to save lives, we need to do what we can to save lives. The question wasn't just about Parksville, it was about more broadly what's being done and available in smaller communities like Parksville. Back to what we've heard from our provincial coroner and the public health officer, they have both very publicly advocated for an expansion of the safe supply program in British Columbia. In Oceanside, doctors, at least the ones that I've spoken to, and it's my understanding that all doctors in the community are not prescribing safe supply because they are very concerned that there are no programs for drug users. And so the question I have is, through the chair to the minister, what is being done in communities like Parksville, but again, small communities across this province, to ensure that people who do have a dependence on these illicit substances are able to have access to safe supply?
Minister.
Thank you, Chair. I mean, I'll just start by saying that, I think that, that we recognize, Dr. Henry recognized in her review of the pharmaceutical alternative program that there are differences in access across the province, and her report makes some recommendations to address that we're reviewing to look at how we can scale up and bring more access to more rural and remote, smaller communities. There is a program, albeit a small program in the members' home area. There are a number of individuals receiving prescribed alternatives, and there are a small number of prescribers who are doing that work. More broadly, I would say that one of the elements that health authorities are scaling up is access to virtual services. We really found, and in particular through the work that First Nations Health Authority did during the pandemic, that virtual services can be very important. neighbors next door in Alberta have a provincial virtual opioid agonist therapy program, and we have now all health authorities either providing access to virtual services as part of a comprehensive addiction management program, and that virtual service is not yet up and running in VHA, but it is on its way. And I would just take a moment to note for the record that the information we've received back from the ministry is that in the second quarter of this year, the average wait time in the Vancouver Island Health Authority for bed-based treatment is 24.6 days.
Member?
Thank you, Chair. 24.6 days is better than the provincial average of 31.5, which was listed before. Challenges is that when I talk to the senior staff that are in MHSU in my community, that's not the number that they're telling me. I'm hearing from both service providers, but also the healthcare practitioners, that access to treatment in my community of Oceanside is significantly delayed, at least 6 months. When I talk to service providers in the community that are trying to keep people alive, I'm being told that there are very limited services in our community for those who have active challenges with opiate use disorder. And when I talk to doctors that are supposed to be a part of this team to address this circumstance, I'm being pointed back to the lack of these services in our community. This is a system that's being built out. I fully recognize that. We're in the midst of a crisis, and so I appreciate the efforts of this government to try to tackle these growing problems. One of the challenges, and I'm not sure if it's in this ministry or the Ministry of Health, is often we see children and youth that have significant challenges that I could never possibly understand, and I empathize with the parents. And they, in the past, were referred to Ledger House in Victoria. Again, not sure if this is within this ministry or the Ministry of Health. It's an inpatient, hospital-based psychiatric service for children and youth that are looking for stabilization, assessment, and treatment planning. What we have been told from parents recently with those who are admitted to hospital, children who have attempted self-harm, who have complex needs, they are in hospital, and often they would then be from there referred to Ledger House and to get the support that they need. What I'm hearing from parents now is that those supports no longer exist and the wait lists are significant. Parents often don't have the skills and the abilities to be able to tackle these issues with their own children, especially if they have multiple children. If it is within the bailiwick of this ministry, can the minister explain what the current situation is with Ledger House, what the waitlist is for services there, and more importantly, are there any investments in this budget that will expand services like that for families, especially in central Vancouver Island, but also across the province?
Minister.
Thank you, Chair. We don't have specific wait times for Ledger, and that's an acute psychiatric facility. If there's been a change to, or perceived change to the provision of services there, it's something that I would like to hear more about, and I'll have staff reach out to the member to just understand what his constituents are communicating to him about the services at Ledger House. I mean, I imagine it's a tertiary facility, but I'd like to understand more about what's happening with that service. When it comes to other sort of youth-based, youth-focused services on the island, there are 6 newer expanded youth short-term assessment and response teams, the Y-STAR teams that provide outreach in community and in-reach to hospitals, working with youth from 12 to 21 experiencing mental health and substance use-related crises. These new teams provided care to and connection to 112 youth between April and September of last year. We have opened Foundry services in Campbell River, in Comox, in Victoria, Port Hardy. There's an additional 4 Foundry sites that are coming to Vancouver Island, in addition to integrated child and youth mental health teams. And those services are all sort of community-based services that are connected with our health system, with our child and youth mental health system, and are meant to provide low barrier access. Foundry also has a virtual app, which is available obviously for youth across the province. So this again is part of the work that we're doing to scale up child and youth mental health services across the province.
Member.
Thank you, Minister. Ledger House has saved many lives and many families. It is incredible the work that they do there to provide stability for children and youth. I would encourage the Minister to not only look into where this current state is, because I have families that are reaching out to me that are being turned away. And this is not the type of work that Foundry does. This is at the other end of the spectrum. And then, of course, the question was what other services like that are being set up across this province. I will just leave that as a wish to the Minister, and noting the time that we have here, I want to thank the Minister and her staff.
Thank you. Seeing no further questions, I would like to ask the Minister if they would like to make any closing remarks.
Yeah, thank you very much, Chair. And just to be brief, I know we've been at this a long time this afternoon. I mean, I'll thank the member for his contributions to the discussion today. Grateful to the member from South Surrey for her interventions and the conversation. The other individual MLAs who came to ask specific questions, and the member for the leader of the third party who also was interested in engaging in what is a very fundamentally important conversation about how we build out a system of mental health and addictions care for British Columbians that provides British Columbians with the care where they need it, when they need it, in the right way, whether that is a bed-based program, whether it is an outpatient program, whether it is a community support, whether it's assistance with a transition from different parts of our healthcare system to another. The work that we are doing upstream to get at problems before they become big is a critical part of the work that we're doing. I'm very grateful again to all of the service providers out there, the clinicians, the peers, the outreach workers, the nurses, everyone who's working across our healthcare system and in community services. Some of those folks were here today for the announcement about the increase in the per diems. They're doing extraordinary work every day to contribute to the care of British Columbians and literally to save lives. So thank you. It's an incredible honor to be able to do this work on behalf of British Columbians.
Okay, thank you, Minister, and all members. Seeing no further questions, I'll now call the vote. Shall vote 39 pass. All those in favor? Aye. Seeing none opposed. Thank you, members. And the motion is carried. So we are now going to go to, I had my wrong tab open until it's Tuesday. There we go. So now I'm going to ask the minister to move the motion.
Honourable Chair, I move that the committee rise and report resolution and completion and ask leave to sit again.
Great, thank you. The question is the committee rise, report resolution and completion, and seek leave to sit again. All those in favor? Aye. Any opposed? Seeing none, the motion is carried. Thank you, members. This committee now stands adjourned.